Welcome to Final BDS Made Easy. Classify cysts of jaw and describe dentigerous cyst in detail is one of the important 7-marker questions from the subject of oral medicine. According to WHO, cysts are classified into epithelial and non-epithelial cysts. Epithelial cysts are further classified into odontogenic and non-odontogenic cysts. Odontogenic cysts are again classified into developmental and inflammatory. Developmental cysts are the odontogenic keratocyst, dentigerous cyst, eruption cyst, lateral periodontal cyst, gingival cyst, and glandular odontogenic cyst. Inflammatory cysts are the radicular cyst and paradental cyst. Non-odontogenic cysts are nasopalatine duct cyst, nasolabial cyst, and median cysts. Non-epithelialized primary bone cysts are solitary bone cyst, aneurysmal bone cyst, and Staphy's idiopathic bone cavity. Starting with the definition and pathogenesis, a dentigerous cyst, also known as a follicular cyst or pericoronal cyst, is a developmental odontogenic cyst that envelops the crown of an impacted tooth. It forms due to fluid accumulation in the layer of reduced enamel epithelium or between it and the crown of unerupted teeth. It originates from the proliferation and cystic transformation of epithelial islands in the connective tissue wall of the dental follicle, which then unites with the lining of follicle epithelium to form a solitary cystic cavity around the tooth crown. Clinical features. It is seen commonly in children and adolescents with a higher incidence in the second and third decades. It is slightly more common in males. It is most commonly associated with mandibular third molars and maxillary canines, which are frequently impacted. It can also be found enclosing a complex compound odontome or involving a supernumerary tooth. Generally, it is painless but may cause pain if infected or if it compresses a sensory nerve, leading to referred pain such as a headache. Its size varies from slightly larger than the involved crown to significant expansion causing painless enlargement of jaws and facial asymmetry. Teeth adjacent to it and involved teeth may be displaced and resorbed with significant displacement, sometimes causing the third molars to lie against the inferior border of the mandible. Pathological fracture can occur in some cases due to the expansion. The cyst can cause significant expansion, potentially hollowing out the entire ramus or extending to the coronoid process, condyle, and body of the mandible. In maxilla, it may cause anterior maxilla expansion resembling acute sinusitis or cellulitis. Radiographic features. It is typically located coronal to the impacted tooth's crown, commonly affecting third molars or maxillary canines. Radiographically, they appear as well-defined corticated radiolucencies with the cyst's periphery engaging the tooth at its cemento-enamel junction. Effects on adjacent structures. As they expand, dentigerous cysts displace adjacent bones such as the maxillary sinus floor or mandibular ramus. They can also cause apical displacement and resorption of adjacent teeth. Different radiographic types include the central variety, which shows symmetric envelopment of the tooth crown, lateral variety, which shows asymmetric expansion, and circumferential variety, which shows complete encasement of the tooth, depending on the distribution of the radiolucency relative to the tooth. Diagnosis. Clinical diagnosis can be made by seeing the expansive swelling in the posterior mandible. Radiological diagnosis can be made by looking at the well-defined radiolucency associated with impacted teeth and hyperostotic borders. Laboratory diagnosis can be made by a biopsy showing a thin connective tissue wall with a thin layer of stratified squamous epithelium, absent platypex formation and Rushton bodies within the lining epithelium. Fluid can be aspirated from the cyst. BD of dentigerous cyst includes ameloblastoma and ameloblastic fibroma. They are multilocular and not associated with the crown of an unerupted tooth. AOT is rare and occurs in the maxillary anterior region. Calcifying odontogenic cyst shows pericoronal radiolucency with evidence of calcification. Primordial cyst. Radiolucency of primordial cyst is close to the crown of an unerupted tooth. Hyperplastic follicle. Normal follicle size is 2 to 3 mm. If it exceeds 5 mm, then a dentigerous cyst is more likely. And OKC. It shows less severe bone expansion and tooth resorption. And the last one is radicular cyst at apex of primary teeth. It may surround the crown of developing permanent teeth. Management of dentigerous cyst is usually surgical. Smaller cysts can be removed surgically, and larger cysts may require drainage and marsupialization to relieve pressure and shrink the lesion by new bone formation. Decompression, small acrylic buttons or rubber sections are placed in the surgical opening to permit drainage, and orthodontic treatment. Retention of the tooth may require orthodontic treatment. Associated diseases and complications. Bilateral cysts are found in basal cell nevus syndrome, cleidocranial dysplasia, Maroteau-Lamai syndrome, and a rare form of amelogenesis imperfecta. Blue domed cyst contains blood, giving it a blue appearance, and there is possible development of ameloblastoma, epidermoid carcinoma, or mucoepidermoid carcinoma from the cyst lining, or odontogenic epithelium rests in the cyst wall. That's it. Thank you for watching. If you appreciate this video, do hit the like button, share it with your friends, and please subscribe to my YouTube channel. Stay tuned for more such videos.